Hello and welcome to the Surgical Academy's tutorial today. This is part of the On-Call Survival series. Today we are joined by Dr. Amani Abdulla, who is going to be discussing pediatric surgery common cases targeted to junior doctor medical students who are starting their first rotation in the next few weeks. Over to you.
Yeah, thank you. Hello, everybody. How are you all? In the pediatric surgery, there is a million of cases of pediatric surgery. As you know, can be divided according to anatomy, like CNS abnormalities, GIT abnormalities, and respiratory tract abnormalities, and so on. But also we have another classifications according to the age, and also we have the classification according to the severity, according to the treatment, and according to the repair. But anyhow, today I just pick the most common cases that you may find at your foundations here. You may came across many conditions, but the most common cases, there will never be a duty without an inguinal-scrotal conditions. You're gonna see babies with inguinal hernia, and you will have to differentiate it. Is it an inguinal hernia? Is it a hydrocele? You have to differentiate between two, how to pick the diagnosis, what are the treatment options, and so on. Also, there is a very common condition we're gonna be discussed, the undescended testis. And once more, umbilical hernia is also common here in UK. And circumcision. Most duties in the hospital you will never miss one of those. Okay. Let us start with the inguinal-scrotal condition. The most common inguinal-scrotal conditions at the pediatric surgery settings are the hydrocele and the inguinal hernia. We put them together because they have the same idea, the same sequelae, the same etiology, but different component. This in the inguinal-scrotal region in the children, and the etiology, because of the non-closure of the processus vaginalis, we call it the patent processus vaginalis, and it is this. You can see the peritoneum at the picture A. This is a peritoneum, and the testis, while the neonatal period, it should be located inside the abdomen during pregnancy, and then it's gonna come down with the gubernaculum via the processus vaginalis till it will gonna be located inside the scrotum. So there is a peritoneum pouch. We're gonna track the testicles from the inside the abdomen to its normal location. And when this occurs, the sac, the processus vaginalis, must be obliterated. In normal setting, there is no patent processus vaginalis. There is an obliterated processus vaginalis. There is no communication peritoneum and between the abdomen and between the scrotum. But when there is a defect, especially in the preterm babies or to unknown causes, there might be a patent processus vaginalis, which will gonna allow the peritoneal cavity content, either the intestine itself or just the fluids, the peritoneal fluid, and that depends on the size of the defect. If it is a very big size and enough to contain the intestine, it will gonna be herniated down there and cause what we call inguinal hernia. And if it's a very small patent processus vaginalis, it will gonna only out a small amount of, and we will gonna call it communicating hydrocele, just like the PKP. This is Hernia with drain inside the scrotum, causing what we call it communicating hydrocele. And it may contain intestine or any intraperitoneal contents. Then we can call it inguinal hernia. And yeah, the hydrocele, we have three types of hydrocele. Either the communicating type, as I just discussed with you, or you can see here in picture D, there is the non-communicating, like there is a partial obliteration of the patent processus vaginalis. You can see it's obliterated up there, just behind, just next to the spermatic cord, and it's open all around the scrotum. There is a space for, so this is what we call it non-communicating hydrocele. And there is a special, and it's rare, but it happens. It is spermatic hydrocele, spermatic cord hydrocele, where there is obliteration of the processus vaginalis upward to the cord and downward, and it's just around the cord. So we have three types of the hydrocele. Yeah. And now let us talk a little bit about the inguinal hernia. The incidence of the inguinal hernia is highest in children under 1 year of age, and thereafter decrease. In premature babies, the incidence even higher with babies born less than 32 weeks. The more premature, the more the chance to get inguinal hernia. And 99% of inguinal hernias are often in type, of course, common than left-sided and more common than bilateral. Of course, boys are affected around 10 times more often than girls. As we talked, we already said the type hydrocele, it is communicating, non-communicating, and hydrocele of the cord. Yeah, how to differentiate between communicating and non-communicating hydrocele? Clinically, we can diagnose and differentiate between two. I made this table. It's easy to differentiate, and it makes sense. You know, the communicating hydrocele, it is communicating, so the fluid can go up to the abdomen and get down to the scrotum. So you may find it fluctuate inside. If you ask the patient in history, you can ask his mother, his caregiver, if it is fluctuate or it is static, and you can just allow a minimal pressure. The fluid or the size of the hydrocele decrease with the palpation, and yeah, it depends on the ambulation of the child. If it is an ambulatory child that play and go there and here, it will gonna increase in size with the playing, with running, and so on. And if he is lying flat, of course, it will gonna get back to the abdomen. You're gonna see no swelling at all. It reverts to the non-communicating hydrocele, which is tend not to vary in size. It is static, it is tense, and even you cannot palpate it's really hard to palpate the underlying testis. That's why sometimes we confuse it with because there is no testis, you cannot palpate the testis. You're gonna think it might be tumor or an inflammation. So you must rule out underlying testicular pathology because it is a hydrocele, because of the hardness of the testicle palpation. So in the non-communicating hydrocele, scrotal ultrasound is really indicated to differentiate between tumors, inflammation, and innocent hydrocele. And in reverse to communicating type, ultrasound is not useful. It is mainly a clinical diagnosis. You can pick it easily. And normally, the communicating hydrocele will gonna resolve because it's mainly a defect in the abdomen and mainly due to preterm delivery, or it's a defect whenever the rectus sheath or the abdominal content, abdominal muscle increases size and the baby grow up, it will gonna close in most cases spontaneously, like at age, so you're not gonna need any surgical intervention or so on. But in the non-communicating type, probably we're gonna need some surgical intervention. And that's it, the inguinal hernia and the hydrocele. Now we're gonna talk about undescended testis. It is a very common condition. And as you can see, there is two different terminologies: undescended testis or cryptorchidism, and there is something what we call ectopic testis. There is true undescended testis and there is something ectopic testis. The undescended testis, the true undescended testis, might be found alongside the pathway of the testicular pathway when it comes from the abdomen, the stomach. You might find it the abdomen, at the abdomen, and we call it interregion or suprascrotal. Those are the most common three places where you can find true undescended or cryptorchidism. While the ectopic testis, you might find it prepenile, superficial ectopic, or transverse scrotum, or femoral, or perineal. So it may find any other way other than the abdomen, inguinal, and suprascrotal sites. So the undescended testis had the prevalence of 3% of all term baby boys, can be seen in 30% of the premature infant, and only 1% will be undescended at 1 year of age because it will resolve spontaneously. Testes are formed at the lumbar level of the posterior abdominal wall from the intermediate mesoderm via the gubernaculum. Then within the urogenital ridge, the gubernaculum will pull it down and it migrates in a predefined pathway from the lumbar area till the inguinal canal. And if this descent arrested anywhere at any point along the normal pathway, we're gonna be having undescended testis. And as I just mentioned, ectopic testis have deviated a position out of this normal pathway. How to diagnose it? Immediately after birth, the lack of palpation, you cannot, if the midwife, she tried to make sure everything is okay in the postnatal examination, it might be detected there, but because it's really small genitalia at that moment, it may be missed and it might easily be picked up in the subsequent visits, or by the mother or by the caregiver. So it really can be detected early in life, either at and 80% of the undescended testes are palpable at the level of the inguinal canal and some surrounding ectopic sites such as prepenile, perineal, thigh, femoral canal, pouch of tennis crown, and yeah, it can be found anywhere, as we mentioned. In the diagnosis, we really depend on the ultrasound, because in most cases it might be we started with the clinical diagnosis. We palpate if it is palpable. 80% we can find it in the inguinal area. If we didn't find it there, then we go to the ultrasound, and it's probably intra-abdominal. So ultrasound is indicated when it is not palpable in the inguinal region. The management of the undescended testis is really delayed till the 6 to 1 year of age, because it has a tendency to spontaneously pull down as the baby grow up. So it depends on the location of the testis. If it is the inguinal region, then we can do open orchidopexy, like having an scrotal incision or inguinal approach, and just fix it, pull it down and fix it there inside its normal position inside the scrotum. And if it is impalpable and locating inside the abdomen, then we go to the laparoscopic surgery and do it via laparoscopy. That is about the undescended testis. And then one of the most common conditions, we have the umbilical hernia. It is common, and you might face one of what is that caused by incomplete through there is the umbilical cord, and when the midwife cut it, usually after separation of the umbilical cord, the normal situation is that the ring must there might the exact etiology is unknown, but usually it occurs through the umbilical vein component of the ring. Yeah, the ring contain veins, artery, hydrocele, and vitelline ducts. Umbilical hernia, part of the all white children at birth have an umbilical hernia, and because it tends to close spontaneously without any complication, this risk it decreased to 2 to 10% at 1 year. Just 5 years, and it is safe as there is no any complications like strangulation or carceration. So we don't go to the surgical management in most cases. Uh, 26.6. The reason not precisely understood. It is also more commonly seen in premature baby. It's all problem of premature and low birth weight babies. The more the birth weight, the more the premature, the more the chance to get an umbilical hernia. But usually the umbilical hernia that caused by premature due to the low birth weight tend to resolve easily and without any it doesn't need intervention. The diagnosis of umbilical hernia, it will gonna be picked up by parents, and they will notice an increase or swelling or protrusion of the belly button, which increase when the baby cries, coughs, or straining. The size of the umbilical hernia defect should be measured because the size is really important. Sometimes, in most cases, as I said, we don't need to intervene. But if the size is more than 1.5 centimeter and the age is like more than 2 years, we have to intervene and close it surgically. But if it's less than that, we need to measure it. And also, we during the diagnosis process, we need to determine the reducibility, the presence of signs of incarceration or strangulation, because those are the indications for surgical repair. Most patients with incarcerated or strangulated umbilical hernia, abdominal pain, nausea, vomiting, those signs, because the clinical and physical patient, and if there is any tenderness, any distension, any skin erythema, you must suspect strangulation or incarceration. Yeah, there is an important point here, because umbilical hernia is a really common condition, and it's really no may resolve spontaneously, and there is nothing to worry about. If it is not strangulated or incarcerated, baby can live happy, well, and good life. But the issue is it is really commonly related with another serious conditions, like autosomal trisomies, trisomy 21, 18, metabolic disorders like leukopolysaccaridosis, and some dysmorphic syndromes like Bequist-Widman syndrome, Marfan syndrome, and those are all syndromes that associated with heart, cardiac diseases, CNS problems. And whenever a child came with umbilical hernia, you should suspect those, especially if you find any macroglossia, any another features that warrant the availability of those syndromes. So do not forget to carefully examine the child to rule out those syndromes. Okay. This is regarding the umbilical. The management, as I said, it is expected management 4 to 5 years. Many hospitals do that, and surgery only indicated if complications occur like incarceration, strangulation, or rupture. It is recommended, as I said, any hernia with the defect of 1.5 centimeter in a child over 2 years, because there is minimal chance of we tend to close it surgically. The last but not the least, circumcision. As you can see, this is the circumcised penis. and this is uncircumcised penis. It is really easy process, and it is a procedure where we remove this foreskin, and that's it. It is a surgical removal of the skin covering the tip of the penis. It is fairly common for newborn in certain parts of the world. It is a religious or cultural ritual for many Jewish and Islamic families, as well as certain Aboriginal tribes in Africa and Australia. It can also be a matter of family tradition, personal hygiene, or preventive health care because it lowers the risk of cancer. So many people do it as a preventive healthcare measurement. But there is some medical indications. The following conditions affect the penis and in rare cases may require a circumcision, like phimosis, palanitis, and condition called palanitis xerotica obliterans. They are all the phimosis, the tight foreskins, where the foreskin is too tight to be pulled back over the head of the penis, and it causes pain, especially in rare cases, might make it difficult to pass any urine. So it is indicated in the phimosis and the paraphimosis, where the foreskin cannot be returned to its original position after being retracted, causing the head of the penis to become an emergency operation. It is needed to avoid serious complications like not to restrict the blood flow of the penis. And also it is indicated in cases of palanitis, where there is infection in the foreskin. It is a very really simple procedure. We just remove the foreskin with the scissors, and we stop any bleeding by cauterization, and we stitch the remaining skin. And it's mainly there is no any side effects, no risk, but there may be a complications. Normal initial swelling after surgical swelling, this is normal. Bleeding might occur. To be honest, bleeding and infection are the most two common possible complications of circumcision. And also there is other possible complication like permanent reduction in the cessation in the height of penis, particularly during sex. But this, if it in most Islamic country and Jewish country, the procedure is done at early age of life, at like 5 years or so, or less, even less. But if it is due to medical issue, it might cause of the head of penis. And the earliest we did the circumcision, it is easier. But if someone must do it at old elder patient, really it will gonna be a little bit complicated operation and having more side effects. Also, there may be a tenderness around the scar. They may need to remove the stitch that haven't to solve. Also, sometimes it is due to technical issue, or it is an operator dependent issue. You might need to go back to theater to remove some more skin from around the head of the penis because you didn't remove enough and that's it. If there are any question, any feedback, I'm happy to receive.
Thank you very much for your teaching. We have one question. If you were to give one piece of advice to a medical student who is about to do their first job in pediatrics or pediatric surgery, what would you tell them?
Yeah. Be aware and sympathize with the caregiver, because most of the pediatric surgery cases are issue. They can be presented from the birth, like, you know, the mother usually came from the hospital, birth to sick child, maybe having some, and she must stay in the hospital. Although giving birth and delivery should be a happy event and a delightful event, but it's really the child didn't. Yeah, it's painful to the child, but you're gonna fix it. The issue most of time is with the caregiver, especially the mothers, you know. So
Thank you very much. So that's the end of today's session. Next week, we'll have another teaching session by Amani, and that will be covering common emergencies that can happen in pediatrics.
yeah.
Okay, have a great evening, and thank you very much.
Yeah, thank you.